Good morning, professorial and classmate. I would like to presenting my seminar which concern with periodontics and other aspects of dentistry. Periodontal health is a prerequisite of successful comprehensive dentistry. In order to achieve the long-term therapeutic target of comfort, function, treatment predictability, and ease of restorative and maintenance care, active periodontal inflammation must be treated and controlled before the initiation of restorative, aesthetic, orthodontic, prosthodontic, and also implant dentistry. So, we first begin with the content, which are including periodontic restorative interaction, periodontic endodontic interaction, periodontic orthodontic interaction, periodontic prosthodontic interaction. First, periodontic restorative interaction. The relationship between periodontal health and restoration of teeth is intimate and inseparable, which means that periodontal health, it is a prerequisite for successful restoration, because for a restoration to survive, the periodontium must be healthy so that the teeth are maintained properly in the dental arch. And also, the adaptation of margin, the proximal relationship, and the surface smoothness has a critical biological impact on the periodontium. Therefore, dental restoration plays a significant role in maintaining periodontal health. So, for long-term survival of restoration, the periodontium must remain healthy and vice versa. We take in some consideration in this part, which are including biologic consideration, aesthetic consideration, occlusal consideration, and special consideration. Maintenance of the gingival health constitutes one of the key for tooth and dental restoration longevity. Special emphasis is paid to the consequence of violation of biologic width, which led to inflammation, recession, and unsightly to the exposure of the crown margin. So, the natural seal that develop around tooth, protecting the alveolar bone from infection and disease, is known as biologic width. Biologic width, which are represented the dimension of the soft tissue, which is attached to the portion of the tooth coronal to the crest of the alveolar bone, which are represented epithelial attachment and connective tissue attachment, in which represented biologic width about 2.04. Why should preserve the biologic width? The biologic width is essential for preservation of periodontal health and removal of irritation that might damage the periodontium. The millimeter that is needed from the bottom of the junctional epithelium to the tip of the alveolar bone is held responsible for the lack of inflammation and bone resorption, and as such the development of periodontitis. Margin placement. A clinician is presented with a three option of margin placement: supragingival, equigingival, and subgingival. Supragingival margin. It has the less impact on the periodontium. This margin location has been applied in the non-aesthetic area due to the marked contrast in color and opacity of traditional restorative material against the tooth. Advantage of supragingival margin. Preparation of tooth and finishing of the margin is ease. Fit and finish of restoration and removal of excess material is ease. And the supragingival margin are less irritating to the periodontal tissue. Equigingival margin. The use of equigingival margin traditionally was not desirable because they were thought to favor more plaque accumulation than supragingival or subgingival margin, and therefore result in the greater gingival inflammation. Subgingival margin. Restorative consideration will frequently dictate the placement of restoration margin beneath the gingival tissue crest because of caries or tooth deficiency, and or to mask the tooth restoration interface. Invasion of biologic periodontal space for additional retention will cause iatrogenic periodontal disease with a premature loss of the restoration. Investigators have correlated that subgingival restoration demonstrated more quantitative and qualitative change in the microflora, increased plaque index, gingival index, recession, pocket depth, and gingival fluid. Biologic width evaluation. Biologic width can be evaluated by three methods: clinical method, bone sounding, and by radiograph. In a clinical method, if a patient experiences tissue discomfort when a restorative margin level are being assessed with a periodontal probe, it is a good indication that the margin extends into the attachment and that a biologic width violation has been occurred. So, what are the signs of biologic width evaluation? The signs are chronic progressive gingival inflammation around the restoration, bleeding on probing, localized gingival hyperplasia with a minimal bone loss, gingival recession, pocket formation, clinical attachment loss, and alveolar bone loss. Gingival hyperplasia is most frequently found in altered passive eruption and subgingival place restoration margin. Number 2, bone sounding. The biologic width can be identified by probing under local anesthesia to the bone level. After anesthetize the area by using a probe, it is referred as sounding to bone, and subtracting the sulcus depth from the resulting measurement. If the distance is less than 2 mm at one or more location, a diagnosis of biologic width violation can be confirmed. This measurement must be performed on teeth with a healthy gingiva and should be repeated on more than one tooth to ensure accurate assessment and reduce individual and sound variation. Number 3, biologic width evaluation by radiograph. Radiographic interpretation can identify interproximal violation of biologic width, but radiographs are not diagnostic because the superimposition, yes. A new radiographic technique used to measure odontogingival unit are called parallel profile radiograph. This technique is simple, concise, non-invasive, and reproducible method. Technique, it is used to measure the dimension of the dentogingival unit. The author inferred that the PPR technique could be used to measure both length and thickness of the dentogingival unit with accuracy. Correction of biologic width violation. If biologic width violation will be occur, it is be corrected either surgically or orthodontically. Surgically, by removing bone away from the restorative margin, either by using surgical crown lengthening, which are designed to increase the clinical crown length, or by using gingivectomy, but can be used only in situation with a hyperplasia or pseudo pocket, more than 3 mm of biologic width, and the presence of adequate amount of keratinized gingiva. But there will be a high risk of interpapillary recession. Or orthodontically, by extruding the tooth from the socket, by applying low extrusive force, or by rapid orthodontic extrusion. There will be a virus technique to extrude the teeth using removable device or fixed bracket. Provisional restoration. 3 critical areas which must be appropriate to maintain the health and position of the gingival tissue. These are marginal fit, contour, and surface finish. If poorly adapted margin, over or under contour, rough or porous surface can result in inflammation, recession, and overgrowth. Marginal fit. Open gingival margin lead to inflammation as this space can harbor a microbe and the extent of inflammation has a positive association with the level of opening. Crown contour. Ideal contour provide access for hygiene, has the fullness to create the desired gingival form, and has a pleasing visual tooth contour in aesthetic area. So it provide a good aesthetic. Because if over contour will be occur, food trap from open contact, overhang, or planar cusp may occur. Poor occlusal design and poor aesthetic and unaesthetic emergency profile of restoration. Subgingival debris. Retraction cord, impression material, provisional material, or either temporary or permanent cement left inside the gingival tissue during restorative procedure can cause adverse periodontal response. The management include examine the sulcus surrounding the restoration with an explorer, removing any foreign bodies, and then monitor the tissue response. And finally, hypersensitivity to dental material. Non-precious alloy like nickel in dental restoration result in the gingival inflammation. So, hypersensitivity response to precious alloy are exactly rare and can be used on aesthetic consideration or aesthetic tissue management. Interproximal embrasure form. Papillae is a very important part in creating aesthetic result, especially in the maxillary anterior teeth. Interproximal embrasure that created by a restoration and form of the papillae have a unique and intimate relationship. So, any change in the shape or form of the embrasure lead to change in the height and form of the papillae, which are resulted in the food impaction, accumulation of microorganisms, and the plaque accumulation. So, too wide embrasure, flattened and blunt papillae, too narrow embrasure, inflamed papillae, and idle embrasure, healthy and pointed papillae. Hypersensitivity to dental material. Restorative material are not themselves injurious to the periodontal tissue. The surface of restoration should be as smooth as possible to limit plaque accumulation. So, resin are highly polishable but have deficiency in strength, porosity, and wear. A glass ceramic and porcelain veneer offer a clear advantage over any other type of the restorative material in maintenance of the gingival health. Non-precious alloy show a hypersensitive inflammatory response.